Good morning, everybody. Welcome to 2026 National Kidney Foundation Spring Clinical. Thank you for joining. My name is Joanna Newman. I'm from U.S. Renal Care Satellite Healthcare, and I'm the chair for this section. And please download the NKF Meetings mobile app and complete the pre-test, evaluation. And then so you can do this on site instead of taking this task home and do it later. And the presentation slides will be available on the mobile app and the Spring Clinical Meeting portal. And please share your experience on the social media, #NKF Clinicals. And I hope you all can consider joining National Kidney Foundation as one of your professional membership. So today, this session is about smooth transition, key to operational success in transitional care unit management. And I have the honor to introduce Dr. Krause, who is the best speaker for this program. Because Dr. Krause had developed transitional care units in 2017 and later helped for Next Stage, and then later helped Fresenius reestablish their TCU program. So who can be a better speaker than that? Dr. Krause is the Chief Medical Director at the Indiana Donor Network, and he has been in this position for 1 year. And this is a large organ procurement organization covering the state of Indiana. He was the clinical professor of medicine in Indiana University and was the clinical chief of the division, the chief medical officer of adult dialysis. Dr. Krause is well published and recognized for his work in home dialysis, HHD, PD, and CRRT. He is currently an emeritus professor at Indiana University and has a named professorship there. Please help me welcome Dr. Krause. Thank you.
Well, good morning. I didn't realize I was at the subway platform, but we'll work around it. All right. So first, thanks for inviting me to speak, Joanna. This is truly an honor. And I left that dialysis organization a little bit ago and wondered if I was going to disappear into the abyss. So it's nice to be invited and still be part of, I guess you have it there and I don't see it there. Oh, that's good. All right, we're good. So we're going to talk today about transitional care units and where we're at. And I did go back and did my job and reviewed all the literature and been a good boy and surprised to find there's really not much new written. So we do have out there good tools. There's some very good articles on how to set it up. And we did a nice descriptive article with Dr. Lockridge a few years ago that's out in the public domain. And so if you Google it, you can find all those things, and they're well enough written. There's just not a lot of science. So we'll go through some of that science as we progress further. But the key question, I think, before you talk about how, you've got to understand why. Should we be even doing this? We can argue that we haven't succeeded at it for a number of years, and some of us may think it's new, and we'll go back into that. But why should we promote transitional care units, or am I just really an old dinosaur up here talking and kind enough to listen? So that's what we'll work on. Here's my conflicts. I think Joanna covered most of them. But I am a purveyor of free advice to anyone, so feel free to call me, email me, whatever you want. I'm happy to talk anytime about dialysis, ESRD, and now most notably procurement. A quick list of the objectives, and I'm not going to read it to you. You've got it there. We're going to talk about transitional care. We're going to have fun, and if I got this done right, we're going to have plenty of time for questions and answers. I really want to hear from you more than I want to hear from me. Okay? This is where I work now. This is the Indiana donor. I threw it in for everybody puts it at the end. I'm not putting it at the end. It's up front. This is who I am. So I work at Indiana Donor Network, which is an organ procurement organization. You can't see my office, 4th floor, way in back on the other corner. That building to the side is our clinical building. So we do a lot of work to be able to do a lot of good and help people live with transplantation, and we're able to procure organs. We have a 6-bed ICU, so I can take care of brain-dead donors right on site. We can do the surgeries there. We've got CAT scans. So the point of this, and we do have jets, because you got to show a picture of a jet if you talk about procurement. But the point is, I want you guys to think about procurement going forward. What I've learned is it's a black box nobody knows. It's so important. So if you have questions, call me. I think we need to begin to understand it, because there's so much misinformation, even on our level, that I think it's worth noting, and it's a great place to work. It's just a wonderful atmosphere. Uh-oh. Oh, no, so we start. Okay. So join at Slido. I don't know if you guys done it. Go ahead, take your QR code. You've got to do this because not very many of you, and if nobody does it, I'll look like a fool. So go ahead, get your phones, hit the QR code, and it should go hopefully right where we're at. And this one you have to work on because it's typing. So just type in the word that comes to your mind about why you want to build, or why we should build, or why we should continue a transitional care unit in your organization, in your dialysis unit, in your neighborhood, wherever you work. And there we go. You're doing very well. Why am I giving a talk? You guys got it. So the point is there's a lot there, and it's about taking care of patients. And we do, in the back of our minds, the people that count dollars and cents want to increase home penetration. And that's what they tell you. That's not why you build a transitional care unit. Take that out. Increasing home penetration is a side effect of a good transitional care unit, and that's what you want. It's not new. It started when I was just 5 years old, so I had nothing to do with it. So it started in 1964 at Northwest Kidney Center, which those of us in home dialysis will always owe a great debt to. And this is Susan. She was the first home hemo patient. A couple things to note. If you think today's devices are difficult, this is what they dealt with every day, right? And they were able to do that. The other thing to note is look at Susan. She's the one in the bed. That's her mother standing up. She looks pretty damn good, right? Pretty healthy. And we think the world of home dialysis, it started with, frankly, reasonably healthy young people. It has progressed to a world today that if we're any good, covers everybody. So when I did home dialysis for a living, everybody was a candidate in my mind. As long as they could talk to my nurses and tell us when there were problems and follow simple commands. So health was not an issue. It was just cognitive ability and obviously no IV drug abuse and things like that, because I have to trust them. It lasted, then in 1981, when I started medical school, Dr. Eschbach said, I think we can do better bringing these patients in, and opened up the first transitional care unit. And again, at Northwest Kidney, they felt at that time they needed to do it because in their world, Northwest Corner, home hemo had dropped to 50%. So let me say that again, because you may have misheard me. Home hemo had dropped to 50%. And they said, we can't have that continued decline and build a transitional care unit. Frankly, very similar to anything we've published more recently, right? It's surprisingly simple. And again, when you look at the literature for home hemo or for transitional care, it's very important you understand because there's multiple studies out there with different results. If the study is we took anybody that we thought would be a home hemo candidate or a home dialysis candidate, and that's how we put them in transitional care, that's markedly different between we took anybody with ESRD. I am in the world that believes you should put everybody through transitional care, and hopefully you'll understand that. You don't pick and choose who goes in it. I don't know what to do with those results. Because frankly, if I have patients and I say, gee, I think they're going to go home dialysis, put them in transitional care, and anything less than 100% going home, that's a failure. So when they talk about 50, 75, I don't know what to make of those things. So when you read the studies and you compare things, just be careful because it's not clear. And make sure you understand who the patients they're studying are. So when I look at it in the literature, I appreciate more is when we took all comers, and that's the way I believe it should, and that's how they started it. It took 2 to 3 months. It took 1 to 2 nursing, which was a lot for them even then, a lot for us now. And they kept doing it for about 10 years, and they closed it because their home hemo penetration had dropped to 25%. So they thought they lost value in it, which was very sad. But what they did notice is they were losing that because patients were sicker and sicker and sicker, which we all know. We see that every day today. So let's keep moving forward and go to, is it moving? It's not moving. I did something very bad. Let's see if I can get it to catch up here. Here we go. All right. Don't touch the computer, lesson number 1. All right. When you talk about anything in healthcare, or virtually in anything, but particularly in healthcare, to any audience, whether it's the CEO of a business, venture capitalist, nurses, physicians, patient care partners, or patients, they have 3 simple needs. And if we're going to get better and expand what we want to do, we have to make sure our discussion, our product, what we want, our transitional care unit, meets those 3 needs. You've got to fill all 3 buckets. Assurance of safety is absolutely paramount. Nobody's going to do something they think is unsafe. You know, they weigh the risks and benefits, and we'll skip people that jump off cliffs for fun. But it's the safety's got to be there. That's got to be the physician, or they don't prescribe it, the nurses, or they won't promote it, the patient care partner, or she won't let her partner do it, and the patient themselves. So we've got to have that assurance of safety. We have to continuously work to reduce burden. And we can't assume we're good anytime, because even though we're much better than what we saw in 1960, we got a long way to go. It's still a fairly burdensome process to do dialysis in-center or dialysis at home. But we should think about how we reduce that burden. What does it take? And that's a lot of what we'll talk about. And then we have to provide world-class care. So that's the why that's behind this. So as a transitional care unit, it's critical that we do this, and if you do it right, it fills this one. It's almost a no-brainer, right? And you got to ask yourself, what do your patients want? They're, at the end of the day, your end customer. And when you talk to patients or you talk to their care partners, and you say, we're interested in improving the dialysis experience, the SRD care, what's important to you? Because we know your doctor's going to measure KTOV, blood pressure, meds, whatever, right? Nothing that matters to anybody on dialysis. What they want to know is, can they live a normal life? Ability to travel is huge, and that's why I loved home dialysis with portable devices and peritoneal dialysis. It gives freedom. And that's just that giant rock lifted off you. If you can go 4 days to visit your grandkids, I couldn't imagine me on dialysis. My grandkids live all over the country, so they left me as quick as they could. And to just say, I can't go because I got dialysis Monday, it'd be heart-wrenching. So understanding the freedom of travel, it doesn't have to be big vacations. It could be 100 miles to visit your aunt, right? Whatever, that's huge. And that's huge to patients and their care partners. And so keep that in mind. Dialysis free time, being able to do things and feel normal when you're off dialysis, and not having that post-dialysis fatigue. That's what patients want. That's the quality you want them to understand when you bring them into transitional care units. And as you grow and empower those patients and their care partners, this again is not new either. This is Picker's 8 Principles of Patient Care dating back to the 90s, right? It's adjusted a little bit. They do a good job. But this is how I founded transitional care when I was at Next Stage. I found this, read about it, put it in the center of our trifold, because I felt it was that important. Now, the 5 people that saw the trifold hopefully liked it, but yeah, but that's what drove me behind the scenes. This is what transitional care has to do. It has, and I won't go through all the levels, but it's got to be freely accessible, right? Which means it's got to be accessible to the poorest patient as well as your wealthy patient, right? The sickest patient as well as your healthy patient. Access is a level of equity we have to continuously struggle with in dialysis world, and we have to continuously do better. Regardless of politics, it just isn't fair that what zip codes you live in determines what dialysis therapy you have, what quality of health care you get, and your access to health care. We have to continue to improve that. Transitional care, when you think about building your unit, understand those things, right? We'll talk about continuity and transition, and that was on your bubble slide. Very good for you bubble sliders. Making sure you involve the family. I can't tell you what I learned as a younger nephrologist. I'd get Dad all set up to go home hemo. And he was excited, and he understood it. He went home and said, honey, we're going to do home hemodialysis. And she said, not in my house, Scooter, right? You got to include it. And then you assume that he's got to teach his wife everything I taught him. That's not fair. So we have to make sure we include that. That's part of the process. This is, whatever you do, dialysis is a family affair. Whether you believe it or not, whether you're in center or not, it's a family affair. And it affects every part of the family, so open the doors, right? Support them, get them comfortable, make them physically well, because you can't learn if you're scared. You can't learn with excessive fear. You will learn by fear. We all learn by fear. Politicians know that, right? You find somebody to hate, somebody to be afraid of, people will vote for you. So we can use that too. You don't want to be sick, you want to travel, you want to do those things. Home dialysis is wonderful. So fear itself is not bad. Fear itself is a learning experience. But being afraid and to the level of fear that you can't learn, it's got to be fixed. Obviously, we have to educate, coordinate things. At the end of the day, it's always about respect. And I would work really hard to get people on home dialysis, and they'll say, Dr. Krause, at this point in my life, I just can't do it. I'm going in center. And I thought I failed, and then I realized, no. It's what's best for that patient today. But even knowing that, I know the door's open for them. They know they can go to home dialysis anytime. They know they can get transplanted and get on a wait list and do the things that many patients don't. So it's very important that we keep that as our level set. At the end of the day, these are the things that are important. The components there are on the left side of your screen. If you're talking to the businessmen, talking to the government, you've got to understand what true outcomes need to be. You've got to reduce costs, you've got to improve care. Lower hospitalizations, that's huge. Increase transplantation, get people on home, get them to get permanent access. You do those things early on in the career of a dialysis patient, you've made great marks long-term. This pays long-term. This is not a short-term product, so that's important. You know, and to do that, you have to stabilize them. You have to make sure you've got a good product in education. You're not being biased, but you're being fair, which means home dialysis is always better. That's clear. You know, you got to be fair, and you got to work on outcomes and complications. And this is why. So on the right side of this screen, risk of death and hospitalization in the first 12 weeks of dialysis, ESRD, is huge. Now, these numbers may have changed. This is unfortunately a little bit old. I haven't seen any more recent stuff. It's 2011, but it's probably still the same, right? Or worse, who knows, right? AKI may have made it worse. But we have to do something if we're going to take care of patients to rapidly reduce that risk of hospitalization and mortality, which means improved care, right? We know 70% of people start dialysis with a CVC in the United States. We also know we're not changing that very quickly. So, and there's good reasons. Over half the patients crash into dialysis and all the stuff that we hear about, and which is true, but 70% still start with a catheter. Most of our patients are really sick. They're not all 18-year-olds with IgA nephropathy, right? They're really sick people. Many of them are malnourished when they present to us because they've been uremic for a while. They're 3 times more likely to be unemployed, and then after dialysis even more, and less than half of them have completed high school. understand your patients. None of that is necessarily bad, but you've got to understand that as you set up a program to them, right? You can't set up a program in Spanish if everybody speaks English and vice versa. You got to meet your needs. Some interesting facts, I like this one. I got this from USRDS about ESRD to just show this, right? Now, the first one is good. Fewer people start dialysis early. We went through a stage where if you sneezed, we put you on end-stage renal disease, right? And GFRs were 15, 18, 20, 25 as a common starting place. Fortunately, that's going back down. It was 10 before, then way up, and now it's coming back down. And I think that's a good thing. You shouldn't start people on dialysis too early. Dialysis sucks, right? Let's be honest. Make sure they need it when you start it. Don't go by a number per se. Diabetes and heart failure is huge, right? Over 70% of our patients have heart disease. You wait a year, they all have heart disease, right? This one is the sad one, right? It's better than it used to be, right? But 40% of new patients today say they've never heard about home dialysis, transplantation, peritoneal dialysis, haven't even explained the basic options of care, let alone not doing dialysis as an option. But 40%. It used to be 60, so we're making progress, but that's not, and that's just some of them. That doesn't maybe not all three. It's probably much higher. So we are failing in getting people access. We're failing in educating our patients to know what's potential for them in the best therapies, and that's why we have to do something different, right? The other thing now, as I think about those that do end up in our chairs, dialysis times are continuing to get shorter every damn year. We all know that's not good. It's just the wrong therapy, and we continue doing it. So we've got to ask ourselves how to fix those things. And showing that phosphorus, which phosphorus is how we understand phosphorus, but phosphorus is a marker of how well we're actually dialyzing people. I think salt and water is by far the worst poison we have. Phosphorus is probably second. You don't control those things, you're probably not delivering great dialysis care. Phosphorus continues to climb. Times to continue to get shorter, we're missing. So in that backdrop, we have to keep that in mind. This is, let's move to home, right? Because that's why most of us think about transitional care. These are interesting curves. So what we're looking at on the left is PD patients, and there's year by year, and you can see there's not much change. But the x-axis is months on dialysis. The y-axis is percentage that switched to in-center dialysis. So technique failure or death, whatever you call it, right? And you can see most rapid in the first 3-4 months of therapy. Then it levels off, and it's got a progressive, consistent slope. And I believe that consistent slope is real and it's physiologic, because as patients lose kidney function and they get sicker, PD becomes less and less a positive therapy. So that slope probably won't change. That's the medical aspect of patients. But that first 3 months, I think is exceedingly modifiable. And the other side is just an interesting thing because it looks markedly different from home hemo. And I'm colorblind as hell, so I don't know what colors anything is. But the bottom line is people that start dialysis. The middle line is people that have been on for a year or less, and then the third line is people who have been on longer, right? And what you notice is that people that have been on longer drop off PD quickly. And they continue to drop off PD at a fairly high rate. People that start on dialysis have a surprisingly almost straight line, but still a little bit of that 3 months. Again, showing that PD, particularly early on, looks to be a very successful therapy. So keep that in your backdrop, because I found that interesting and frankly a little bit surprising that the new starts stayed on PD so well. This, on the other hand, is HHD. And what you notice, year over year, we're getting worse. Year over year, we're getting worse with retention. But look at that slope, the first 6 weeks of HHD. It's almost a straight line up. It's awful. That's when the patient is going to drop, is in the first 3 months. You get that patient to go 3 months or longer, they stay on therapy. You'll note that slope is much different than that slope. It's slower. People stay on therapy. If you go to home hemo, you stay on home hemo if we do it well, if we start well. And I think that's incredibly important. The other thing, again, this one, not so much the difference when you start. The slope's bad at all of them. Slope's actually worse if you've been on it longer. But the important thing to keep in mind of that slope is, when do patients start, right? And so when you look at PD, which is on the left bar graphs, they start when they start dialysis, right? And within the first year, certainly, almost 90% of all patients that do PD start in that first year, with almost 60% of them starting at the time of initiation of dialysis in the United States. Home hemo is a markedly different animal, as you can see, right? And 45% start in the first year, but nobody starts at the time they start dialysis. The first blue bar is what, about 8%. So very people start dialysis in the USRDS last year, and immediately 45, a little less than half patients are in the first year, but the rest is after I've been on dialysis, in-center dialysis, for a long time. So these are more seasoned, different animals than the PD patients. Just interesting facts to fun and share. Now, I can't talk about anything with ESRD without talking about transplant. So we're going to do a little bit of transplant. The line on the left is the percentage of patients with ESRD that are transplanted. So that includes end-stage renal, hemo, in-center, home, and transplant, right? And what you notice is there's a slight, and they brag about that huge rise in slope, slight rise in slope. Now the other thing to keep in mind is patients on transplant live longer. So if everything was status quo, the slope should rise, because hemo patients will die off faster than transplant patients, and you'd see the percentage of people with transplant should go up. That's about 35%. That sucks. That's real. UK is about 52% of patients up with ESRD on transplant. We can do better, right? And we should do better, because the top graph there is showing you graft survival. Does the kidney work that we put into you? And the answer is yes. This is a 75, nearly 80% 5-year graft survival in the United States with kidney transplant. And importantly to your patients, it's an 80, 85% patient survival. Now, what's the patient survival of 5 years on dialysis? 40%. 40%. Yes, and there's differences. You know, it's not necessarily apples, but it's not that much of apples and apples. So clearly, our patients need to understand transplant better. And we have to do a better job to get them there, and we have to do a better job of how we get organs and all the stuff. That's a different talk. And this is just another way to look at mortality. Transplant way down at the bottom, with improving and then a decline when COVID hit, right? COVID kind of unfortunately took us in the wrong direction in so many ways. But dialysis patients is the top red line, markedly higher than that bottom, whatever color that is, I'll call it gray line. And it just tells you that patients live longer with transplant. If we're taking care of patients, we have to, no matter what business we're in, have to understand that, and we have to be positive for it. So let's go back to our patients now. I think it's fair to understand we've got a lot that they have to learn. They want to live normal lives, and we have to get them there. And we have to know our options. We have to know the benefits of all those options. So think about that patient that plops in your chair day one. They are scared terribly, right? They don't know what's going on. They don't have a huge health literacy when it comes to ESRD. Some days I wonder if I have a huge health literacy with ESRD. It's hard. There's a lot there. Their emotions are very high, and it's brand new. And again, they're not going through it, hopefully alone. They've got loved ones in their house, family, friends, whatever, that going through it with them. But they're all feeling the same way, right? So you've got to take that ball of clay and mold it and figure out how to get there. To teach, you have to listen. It's taken me a long time to learn to shut up and listen before I talk. It's very helpful in meetings, by the way. Listen to everybody else and then tell them what the right answer is. But listen to your patients, listen to your family. Understand what they really want. You can't direct them to modes of therapy, how to dialyze hours per week, all that stuff, if you really don't understand what the patient's needs are and the family's needs. And it shouldn't just be the doctor. This really should be a global decision. Our nurses, our social workers, dietitians, the patient's peers, other dialysis patients. Use everybody to help educate. Listen to everybody's opinion. I learned so much by listening to my social worker when they walked in the room and said, Dr. Krause, Mrs. Smith is depressed. Back in my mind, I'm going, so what? Everybody's on dialysis is depressed. And then I realized my social worker is picking up something that's very important. And I listened, and we talked about how to make things better. So it's very important to do that. You got to educate patients at their level. There's nothing worse than talking above a patient, except talking below a patient. So if I have a level of literacy that's here and you're talking to me here, that's not going to fly very well either. So understand their level, teach them how they learn, whether it's by touch, by feel, by videos, by audios, by reading. Understand that and make sure you have the ability to do that. And again, that important fact of teaching them when they can learn. Can't do it day one. I'm scared, I'm angry, I'm usually sick, and I don't remember anything you just said to me. It's bad, when you leave the hospital, they tell you all these things you have to do. You can't remember that when you get home, right? You've got to know when they can learn. So you've got to get them to that point, and you've got to give them the time to get there, and you've got to make them healthy so they can get there. Provide access to care, as we talked about, and then be very consistent in access, transplant, and home discussions. This is not about growing home. This is about rehabilitation and subspecialized nursing. Most of you are too young to remember, but when rehab hospitals started opening up, I'd walk in the room and say, Mrs. Jones, I think you need to go to the rehab hospital. And she'd look at me and say, no, I'm in the hospital, I'm going home. And if I did not sit at that bedside and say, this is why I want you to do this, Mrs. Jones went home and came back to the hospital 10 days later. Same thing is true with transitional care. You have to sit down at the bedside, you have to say, this is why we're doing this. We want you to understand therapy, we want to make you healthy as quickly as possible, and help you live as long as possible, make the right decisions for you. You can't do that 3 days a week in a chair, right? So those are the important things. Think about that dialysis patient, right? When they start. Monday, Wednesday, Friday is how we start them, right? We get their weight down. They come fluid overload like initial man. We get their weight down over the week, probably a little bit too fast ultrafiltration rates at times. They go home on Friday, and where do they come back on Monday? In heart failure, potassium's up, because they don't know what the hell they're doing, right? And then you're back to square one. They can't learn. So understand the process that we've built and see if we can do better. Understand that we have to gently medically stabilize them. Ultrafiltration rates that are lower, and I've got a slide to show you that again. Make sure it's a welcome environment. It's scary as hell. Sit down, sign these 600 pieces of paper that you haven't read. And then we talk, and they don't understand, and they don't feel good, and they crash at 3.5 hours and whatever else, right? Give them the education, the modality, not only modality, but also on nutrition, finances, everything that involves their care, because they need to know that. Now, they don't need to know it on day one, but they need to know that. Make sure you're supportive, make sure you coordinate things, and always, always, always think about where that patient is today in their emotional, medical, and psychological ability to learn, right? And improve it. So, which statement is most true about patient referrals? Let's get your phones out. You guys were lolling your Slido minds away. So, which is most true about the patients? Most true. All incident patients should be referred to a transitional care unit. Only interested patients should be in home. I guess I gave you this answer earlier. Interested patients in home therapy should be referred to. Any patient experiencing change should be, any change in care should be referred, and patients in a hospice care should be referred. So I kind of gave you some sneaky answers there too. And you guys are I like that because I did say, I remember Dr. Krause 2 minutes ago saying all patients should be referred, with these SKD care should be referred. But I'm on PD and it's failing. I'm going through a transition. I'm in center and I've been admitted for heart failure and my thrice weekly dialysis is failing. I'm at a transition. I come back from transplantation. I'm at a transition. All transition points have the same things in common. We talked about incident patients, but it's all of them. So in my mind, yes, that failing PD patient, if it's appropriate, could go to transitional care or experience the difference in your home unit, your choice. All new transplant patients, any transition point, and I really believe patients that are admitted to the hospital, you should ask yourself, why were that patient admitted to the hospital? 80% of the time it's salt and water. Thrice weekly dialysis doesn't manage salt and water. Home dialysis, transplantation manages salt and water better. Think about transitions for those patients. Think about putting them through transitional care. So I like the second answer a little better than the first, but the first one clearly counts. And the third one's fine. You know, the only interest in home therapy is if that's your goal. If your dialysis unit says this is what we're going to do, there's nothing wrong with that. It's just I think it can be expanded, but it's got to be where you're willing to spend your money and how you want to do it. So which patient should go? Basically any patient that can understand education, cognitively intact, or as a partner that's willing to sit with them is cognitively intact, should be considered for transitional care at any point of transition. If you're going from a SNF to home, if you're going to the SNF perhaps, but certainly from the hospital to home, from the SNF to home, that's a huge transition. It's just like an incidental patient. All those patients. So while there's challenges to some of these things, and again, I took it from the literature, I think you can get past all these things, right? Certain things are probably not worth it. If you're in hospice care, you probably don't need transitional care. You probably need transitional touch while you're in transition, right? Everybody needs that discussion, but hopefully we're doing that. But coming to and forth your transitional care unit probably isn't necessary. Cognitive impairment, it's just if you're not going to benefit from it, perhaps. But even if you think medically I'll benefit, it's reasonable. And unstable living arrangement, I think should go. I wouldn't have put that one on there. That's not my, because you never know when it's going to improve. You're still in a transition. You still have to figure out the care that's best for you today. Just because I don't have a home doesn't mean I should learn my options and we can think about where I can do those things. We've had homeless people do peritoneal dialysis, right? They go to the church, pick up their supplies. One lived in a homeless shelter. He swept the floor. He had a kid going to in-center dialysis. Was socially impossible. The hospital or the living facility he lived at said, fine, bring your PD supplies here, continue to help us with the simple chores, and you can do your PD here. And he was able to keep his child, he was able to get his kid to school and do the things he needed to do. So understand your definition of unstable and mine may change. Give people chances. Nobody succeeds if they don't get a chance. Where to put, there's a lot of talk about this. Where should I put my transitional care unit? Again, doesn't matter. I can make it work any of these situations. The in-center floor with a 1 bay or 2 bays transitional care, probably one, makes perfect sense. And people going to in-center dialysis, this is the great part, they go to in-center dialysis, they see the other people, they think, well, that's wonderful. I'm not sure that happens much, but we say that, but that's okay. It's not a bad place to do it. It's economically feasible and simple. In your home unit is fine, but transitional care, at least in the United States, has to be billed as in-center care. So understanding where you put it, you still have to get those chairs approved for in-center dialysis. So you can't just say, I'm doing transitional care in my home unit and bill for it and be kosher, right? And certainly a standalone TCU is fine too. But any of those will work. Make sure you got the billing right, make sure you understand it. And all of them have worked. And all of them have failed, right? So you've got to make it work, but where you put it is probably the least important. How you educate to me is exceedingly important. That first week of care is to make you feel well, comfortable, get rid of your pulmonary edema, control your blood pressure, and get all the cobwebs out of your brain from uremia. Not going to learn much that first week. Don't set up an aggressive educational platform the first week. And even though these say weeks are relative, right? 1 week could be 7 to 14 days. But you talk about the modalities, the options, CKD, what ESRD means, and then you help them make the modality choice. It's just a series of consistent education at the patient level that gets them to the ability where they can make choices in their life. How to dialyze the patient at TCU may be one of the reasons I no longer work for a dialysis organization, because I have very set in my way. My thought is very clear. Frequency matters. Time on dialysis and frequency matters at all points of care. As we talked about, I dialyze you Monday, Wednesday, Friday, you come back Monday in heart failure, we're not getting anywhere. I dialyze you 5 days a week. I can go with rational ultrafiltration rates. I can get your electrolytes controlled, and you will feel good at the end of that first week, period. You come back for that second week, you're ready to go and ready to go. Now, in my Krauss world, that means no 2-day gap. In a staffing world, that becomes a little difficult. So the models I usually see are Monday, Tuesday, Thursday, Friday, which I don't like. But the nurses need Wednesday off. I don't know why, but that's okay. Monday, Tuesday, Thursday, Friday. And I know nurses work hard. Don't take them wrong. I've seen 3 days a week, and Monday through Friday are the most common ones. In my world, Saturday would be done. And you can do Saturday is not transitional care per se. That you're in the in-center unit if you got that model. Just dialyze Saturday. Day off from education, but you're in. So you don't have a 2-day gap. So I would dialyze Monday, Tuesday, Thursday, Friday, Saturday, or some configuration of that. No 2-day gaps. And figure out how to make it work with staffing. Because again, that weekend off puts us in trouble. And what we know by frequency is we'll start at the bottom. Bottom left ultrafiltration rate, you guys are aware of the 10 cc's per kilo per hour that everybody talks about. It was looked at again. Very good study. I don't know why it hasn't been so widely discussed. But what they found at RRI is that was true along all weights, but the mortality doubled if you were over 100 kilos. Doubled. And what it turns out to, it is volume. So if you want to keep mortality controlled, you literally shouldn't be ultrafiltering more than 750 cc's an hour. Lower than most of us usually go, especially with how we're dialyzing today. As you go up, mortality goes up. All sizes. Obviously, if you're really small, you want to go about 450, 500. But 750 should be your max, maybe 800. Walk through the dialysis unit and ask yourself how many people are being ultrafiltered at that low of a rate, right? That takes frequency and time. 5 days a week, 15 hours. In the Mike Krauss world, my opinion, that's where I would go, right? And when you look at just the pressure on the heart, which are the other two sides, dry weight change and what they call TIFL, which calculus of what the fluid status is, frequency reduces it more than anything else we do. And remember, salt and water is the most important poison. Frequency matters, even when we start dialysis, right? And so I know we have constant conversations that the patient doesn't want or the doctor doesn't want. Understand what you're doing. Find the indication. I guarantee you in 90% plus of your patients that start dialysis, I've got an indication for more frequent dialysis. Gives you time to educate, gives you time to get the patient safe and better quicker so they can learn. So in my mind, this is very aggressive, and this is the way you should do it, and I realize that's not necessarily the way it's done, right? So be aware of that. So if you work for me, that's what we do, but you don't work for me. Now, who should be the team? Because some places I've heard, well, we'll just put a nurse and a tech there and not worry about anything else. No, this is about global care and education. Everybody has to be involved. The physicians, home therapy staff has to come in once in a while to educate if they're not running it. In-center staff clearly have to be involved. Your vascular access coordinator is the same. In fact, I want them to be more aggressive because I want that access scheduled to be placed by the time you leave your transitional care unit. Dietitians, huge changes, right? Huge changes. Got to be there. And understanding which patient they're looking at isn't the same patient that's been in the chair for 3 years. social workers, education, all the people, right? It's very important. It also is very important that you have a champion. I'd like to have at least 2 champions, but I'll take one. Either a physician champion or a nursing champion. You gotta have a champion there. Somebody this is why I get up in the morning. What's going on? How's it gonna make it look? Look at the transitional care unit, even if somebody else's patient's there. Understand it, because champions make things grow. Lack of a champion, you start at a status quo and then you'll dwindle off. This has got to be a passion, and I think it's a great passion because, as you'll see, it makes a difference. Reduces hospitalizations, reduces mortalities in some smaller studies, not yet 100% proven, but I think it's there. Certainly we know shorter times on wait lists, higher rates for transplantation, increased home utilization, even when it's all comers, and better vascular access. These are the goals of care, right? This is what you want to do. So we looked at it when we set it up, and we took all comers, 724 patients in over 50 TCUs at the time, 48 TCUs at the time, and compared it 3-to-1 to matched patients on dialysis. So we did our very best to compare apples to apples. It wasn't the healthy patients referred to transitional care, the sick patients went in center. No, they looked the same. And when you did that, over the short period of time we had, we saw more home utilization, up 2.5 times. We saw better AV access. And we saw better referral for transplantation, significantly different. Interesting enough, in your dialysis unit, 18% of your patients are on transplant wait lists. We can do better. This helps. And we saw trends towards decreased hospitalizations and more improved mortality. And when it was reanalyzed in a different way, and you know statisticians, they can make anything look good, but when they reanalyzed it in a reasonable way, it was improved. It just wasn't published. So we're getting to the point where I think there's plenty of real good evidence to go to your people and say, we need to do this because it's the right thing to do. And go to the businessmen and say, you figure out how to make it work. But frankly, if you dialyze with more frequency, your business people will be quiet. And you got to overcome barriers. And the barriers aren't just the patients. Frequently, it's the physician. And they assume the patient lives too far away. They assume that it's harder on me as a physician. They don't like more frequent dialysis all the time, and they don't have the capacity. All those things we can overcome. All those things. Where you build your transitional care unit is very important. Make sure you have physician champions supporting it as you build it. Get over they're not barriers, they're hurdles. Get over the hurdles, right? Educate the physicians before you start. Get some buy-in, right? Find the location that's correct. Make sure the discharge planners at the hospital understand so they refer them to your transitional care unit. That's the first discussion they have because they understand that's what they would do with rehab. Make sure the patients understand why you're doing it. You just can't say, hey, you're going to go here, which is 5 miles further than the other dialysis unit, and we're going to dialyze you 5 days a week, not 3 days a week, because the patient's going to give you sign language, right? You've got to understand and help them understand why you want to do this and why it's important for their care. Plan for capacity. You know, the fastest way to kill a transitional care unit is to say, I'm sorry, we don't have any room. I'm sorry, we don't have any nurses. Call us in 3 weeks. This patient's being discharged from the hospital today. You don't call in 3 weeks, right? You've got to be able to say yes. You've got to up to the scale. You've got to know what the scale should look like and just work very aggressively on that. And establish acceptance and buy-in so that we can educate the patients and everybody's on the same page. It is about being a rehab center. It is about subspecialty care. These are the sickest, highest risk patients that you're going to take care of. Give them the best care to get there. And I think it's perfect for AKI as well. We can have that discussion offline, but those people are just as scared and frequently sicker, right? Now, the AKI guy that's making 3 liters a year and the creatinine's coming down, no, that's fine. You know, that guy's gonna be off dialysis in a week. But most people that start with AKI end up on dialysis. The patients that start ESRD with AKI have a higher mortality rate in your dialysis unit after they switch to ESRD. They have lower access placement rate, and they have lower transplantation home acceptance. That's not acceptable. They need the education of transitional care units. If we do things better, if we do things correctly, we should expect and demonstrate better outcomes, better adherence, And lots of studies out there that do talk about adherence. Less hospitalizations, more transplant referrals, better access care, and increased utilization of home therapies as a nice side effect, right? All the things you want, all the things you would want if you were a patient. If you accomplish those things, the value is there to your payers, to your business people, to your patients, frankly, to society. So that's why we do what we do, and that's why you want to do that. Let's talk quickly about PD to home hemo. How are we doing? Well, we're good. All right. PD to home hemo. What we know is if patients transition to home hemo, they do better. Now, I put this study up there because the numbers look great. I mean, it's huge improvements, right, between the two. It's not apples to apples. Healthy people went home, sick people went to in-center. So be careful as you look at it. But nonetheless, the trend is impressive, right? It's a small study. I think it was Canadian, if I remember right, but very nice. More importantly, when we look at it for all comers again, right? And you get the people that go to home hemo and the people that go to in-center, and you put them together so they're matched. In this case, it was 7-to-1, so that you got good adjustments for risk factors, and you're comparing apples to apples, sick patients, healthy patients to healthy patients. When you do that, patients that went home, or on the left side of the bars going down, had improved hospitalization rates, significantly half the hospitalization rates. They had improved survival, 5-year survival, and improved transplantation. Transplantation, not just waitlisting. This is why you want to look at those transitions and give them the care they want, move them to the best therapy for them, and give them the best options in life. Long-term survival, better quality of life. So, you're all in now. What's going to stop you from doing this tomorrow? And I have no idea how this will show, so we'll see. Whose money? No, just kidding. Money stops everything that we do sometimes. It's sad. Very good. So how do we get over that barrier? Everything on there is fixable. This is about education. This is about passion. And remember, when you talk to an administrator and they say no, you've planted a seed. And you come back later and you plant the same seed and you water it and you fertilize it. Eventually, you're going to get a tree to grow out of the guy's skull. And they'll understand why you do this. It's a hurdle we've jumped in virtually everything we do, right? It's easy to say no to change. So you educate, you're persistent, you pay attention, present patients that would do well, right? Look what we did to Mrs. Smith. I think we could have done a better job, right? Make sure they understand. There are people that will discuss the finances, but it's about being persistent and working. Okay. Now it's your turn. I'll take questions. We can tell jokes, whatever you want to do. I'd like to hear your thoughts. If everybody can hear, we're recording, aren't we? Yeah, I probably should come to the mic. I'm sorry. I was going to say no, but then I realized I'm probably being a bad speaker.
Thank you so much for that. Quick question. So in terms of, having a TSU program, does it really matter what kind of dialysis machine you're using? Does it matter if you're using like a standard in-center dialysis machine, or is it better to use like a home machine, like a next stage machine?
So I will tell you that I no longer work for any company that makes dialysis machines. Dialysis machines push blood one way and dialysate the other way. So technically, it shouldn't matter. Now, if my home program uses machine A, and I won't give names, but if it uses machine A, why wouldn't you use machine A at least sometime during the transitional care unit? So what I promoted just for finances, if nothing else, is you start the first couple of weeks on a standard conventional device if you want, and then the last 2 weeks maybe you use your home device. It does two things. One, it's a little bit cheaper because the system's set up for that probably. Two, the patient knows what it's like to set up that big monster ugly machine. Now they're beautiful. That big monster ugly machine and move to the home device. And they go, well, this is complicated and I could do this. So I can make an argument for any way you want to do it. I do think if you use a conventional device, you should have access to the home devices. And for the right patients at the right time, you bring it in and teach, right? And you give them the smiling face of the home nurse at that time. Because the other thing is you want them to know what the home nurse is, who the home nurse is, and what their team would look like at home. I can't imagine anything scarier walking in and meeting people for the first time that are going to take care of me for the rest of my life, right? So I would always refer people to the home unit, with creatinines of 3. Not because I wanted to start them on therapy, because I wanted them to know the team, know the devices, and know what the options would be, and maybe have a positive outlook toward the future. But always, I like the exposure to home devices. Same thing true with PD. Have the ability to bring it in so they can at least touch it and see it and smell it. Good question. Actually, excellent question.
There's differences in local, state, and national requirements for licensing and certification. Is there something different with TCU?
There is no certification, excellent question, no certification for TCU. So each dialysis organization does their own. So I worked really hard when I was at a dialysis organization to make sure that we trained everybody that did their job to do TCU care. I think that's important. From a billing standpoint, it looks like TCU should be in the in-center unit, right? Just to say you're doing in-center dialysis. And then you have to write the order so that you justify your more frequent dialysis. You should make sure any person you put into your transitional care unit understands what they're doing and why they're doing it. But that's true for any policy and change that you do, right? I make sure in my present job that people are well trained to do the position they're about to take. I don't say, you're doing a great job as a tech, why don't you be a nurse tomorrow, right? You work into it, and it's your responsibility to train the people to where they need to be. Because you're not going to walk out there and find TCU nurses, right? You make them, but you have to educate them, you have to give them grace, and you have to understand the process. Very nice. Other questions, concerns? Don't be chicken, I don't bite. Much.
Thank you for a great talk. I really appreciated your focus on patient education. Are there any resources that you use for patient education that you found particularly helpful?
We created our own, right? I created my own when I was at Next Stage, and I worked with the nurses closely. We brought things in, and I could tell you if I could remember what they were, but we brought things in like heart rates and things like to train the nurses. A lot of education there. Patient, a lot of the stuff would be from the organization or device manufacturers that does it. So, but we would make it focused for TCU, and we would make sure that everybody got the same education. I think we're done. Thank you, everybody. I really appreciate it. I hope you enjoyed it.